Morning. Welcome to another session of short course in clinical epidemiology. So this week we are doing a different topic, something which we have not done previously. This is an ageist checklist. We have previously done critical appraisal of a guideline. So a guideline is designed and it is put into practice for people to follow the guideline. So to assess whether the guideline is being implemented properly or not, we do certain audit, and sometimes the guideline development group designs some audit criteria. But to see how effectively a guideline is being implemented, is there a guideline or a checklist? There have been some guidelines which have been involved previously, but now recently in BMJ, checklist called ageist checklist has been published. So we thought we will use that particular checklist to see if one of the NICE audit reports which has been published, whether it has followed this checklist or whether it is slightly different, or and if we are going to design an audit criteria, whether we can use the same checklist that NICE has used, or whether we should adapt it according to the AGES criteria. Those are the things that are subject to discussion. So we thought we need time to discuss all those aspects today. And Dr. Anuka will be doing that presentation. So she has put in a lot of effort. She has gone through hundreds of pages of documents and audit reports to make this presentation. So we look forward to listen to her presentation. Thank you, Anuka. I hand over to Dr. Anuka.
Thank you. Good morning. Thank you for joining for today's session. Today I will be talking about AGES, which is a recently come out guideline for evaluation of guideline implementation. So the outline of my talk would be, we will go through a recent audit by NCPOD, and then we look at this new tool and see how they align with each other. Coming to the clinical scenario, suppose you are the head of the quality management center in your place. You have been asked to assess the quality of care provided to patients after the discharge from medical ICU, from post-ICU rehabilitation. Your institute follows the NICE guideline for post-rehabilitation after ICU care. Now you have been asked to assess the quality. How would you proceed? So the general thing would be to do an audit to see how much they are adherent to the NICE guideline. So you come across a recent assessment report which looked at another England and Wales, which also follow the NICE guideline. So this is titled Recovery Beyond Survival. This looked at the quality of rehabilitation care provided to patient after admission to ICU care. So you come across this recent audit, and this is how they have started. They have provided an infographic summary. I will come to that later. And then you have two questions. One, have they assessed it comprehensively? Is there any other better way to assess it? Now, coming to Recovery Beyond Survival 2025 London. So this is done by the NCPOD, that is a National Confidential Inquiry into Patient Outcome and Death. This is their website. This is a recovery. This is the audit we will be seeing today. But actually, this year they have actually come out with multiple audits. So there's one on joint care, review of the quality of care provided to children and adults with juvenile idiopathic arthritis. Another report on end of life care, planning for the end. So this is an independent body which does multiple assessments. This is a company and it's a registered charity. Now the current standard of care, so this audit is done in England and Wales. Their current standard of care is they follow this NICE guideline, CG83, which is rehabilitation after critical care illness in adults. And these are the other guidelines they follow. This is part of the standard of care. Now, this audit was a review of the quality of the care provided to patients after an admission to ICU. So, this is titled Recovery Beyond Survival 2025. The cohort, the patient group they looked at were all the patients aged 18 and above who was admitted to ICU for 4 or more days between this time period, October 22 to December 22nd, and survived after discharge for rehabilitation. This was funded by the NHS England and the Welsh government and some other individual projects. So this is the format they have reported in. So it starts with the context, supporting information of the guidelines which institute follows, infographic summary which we had looked at. They start with recommendations, what the patients say in patient's words, and they have 7 chapters. So chapters are as follows. They start with a summary, demographic, rehabilitation in ICU ward and ICU hospital, then the multidisciplinary delivery, step-down care, patient family involvement, and the quality of the care. So this is the format they have presented the guidelines in. So is there any other format for assessment? So what we know that adherence to high quality guideline will improve outcomes, reduce expenditure, rational allocation. And it's not enough to give a guideline. We need to assess the success of how much it is implemented. And there is a need for a comprehensive tool to evaluate the success of guideline implementation. To address that bridge, recently BMJ has come up with a new tool, AGES, so development of a generalized tool for evaluating success of clinical practice guidelines implementation. So what is AGES? It stands for Guideline Implementation Success Assessment Tool. It is a generalized framework how to report and how to audit. It is based on the REAIM model. It is an acronym for Reach, Effectiveness, Adoption, Implementation, and Maintenance. So these are the 5 dimensions they are looking at. And they've given definition for each of the dimensions. For example, reach means receive, read, and understand the recommendation of the clinical practice guideline. So they looked at 5 dimensions, which will be coming to. And this is the checklist for ages. So they have 5 dimensions and they have items. Each dimension has few questions which needs to be addressed. So they have total 18 items and 5 dimensions. We will be looking at that in detail. While the development of the tool, they have also looked at multiple other evaluation tools and they've come up with this tool. So ages, how is the evaluation reported in the current checklist which has come out, recovery beyond survival. So today we are going to do something different. Normally we do a critical appraisal of a study and look at if they followed a checklist or how it is done, look at the internal validity. But today we are using this tool and then we are comparing with another tool which did a audit of a guideline. So we'll use the AGES tool and see how it was reported in the other audit, which is the NCP. So coming to the first dimension, which is reach. So this has 3 questions. The first question is, the definition is extent to which the guideline reaches and is understood by the target population. So we will do it in 3 ways. We will see how it is reported in the checklist, how it is supposed to be reported in the checklist, how it is given in the current guideline, and what is the inference we can do. So first, did you know about this clinical practice guideline? So based on the AGES guideline, it has to be answered in yes and no and given details. So in this, they have not mentioned about how it is, but they have said that this is the practice guideline and the standard of care. So I have given it yes. So this is the guidelines and the standard of care for them. So they know about this guideline. So this is the channels, National Health Survey and the NCPOD. So these are the channels which they follow. The second question was, when did you know about this clinical practice guideline? So I have given no because they have not mentioned so ideally this year and the month has to be specified. That is not mentioned. But this probably may not be applicable. It's already implied because this is their standard of care. They follow the NICE guidelines. So they have not mentioned specifically the year and month, but most of them are expected to follow this guideline. The third question was, how did you get to know about this guideline? So you can answer it in multiple choice question. Here they are partially put. So they have mentioned the ICS, NICE, NCPOD, but the timelines and channels are not mentioned. They have given where the guidelines are taken from. We can go to the links and read the guidelines. The next question is about adoption. So question 4 is, has this guideline been adopted in practice in your institute? So it has to be reported, was it presented or is it used as a daily reference or is it adopted as a part of the regulation of evaluation criteria? So this they have written, they have actually mentioned, yes. So they have given it in this format. So they have said only 42.2% of organization reported having a standard operating procedure. And people who followed the procedure, only 24 out of 70 had reported audits. And out of them, only 8 had audited the rehabilitative service in the previous 12 months. So they have talked about adoption. Next question is, to what extent do you agree with this clinical practice guideline? So this is a standard of care, there's strong consensus. They start saying that they support the previous guidelines. Next question is, have you adopted this clinical practice guidelines in your practice? So yes, they have answered this. So they have said that inconsistently the guidelines have been adopted, and this is how they have given it. So this is one of the parameters: quality of rehabilitation care in different centers. So they looked at ICU, ward, and post discharge. So this is how they are given in a graph form. In the based on ages, you can say yes or no. This is how they have given. They have looked at how many professionals were meeting the standards. They have looked at who are the professionals involved in the rehabilitative care, and they have given detailed data for the same. Next question, when did you start adopting this clinical practice guidelines in practice? Specify the year and months. So this they have not provided, but probably this is not very relevant because it's implied that as soon as the guideline came on in 2029, they must be following it. Sorry, 2009, they must be following it. The third is on implement. The third dimension is on implementation. To what extent did you follow the recommendations of this clinical practice guideline? According to ages, it has to be reported from 0 to 100%. So they have said it, and this is a format they have said. They have said it's variable across setting. So they have showed at different settings. One is the organization with healthcare meeting standard. This we have looked at before. So they given how many percentage of people are meeting the standard. They have looked at delivery of rehabilitation in ICU by different professionals. That also they have mentioned in percentage. They have looked at the overall care, quality of rehabilitation care, which they have provided in this graph. The next question is, what percentage of eligible people have been treated according to this guideline since its adoption? Based on the ages, it has to be provided in 0 to 100%. But here they have actually given in the first infographics. So they have told only 30.1% had a baseline screening. They are told in the ward 25.9% of patients had comprehensive assessment for rehabilitation. 48.6% had who were followed up by comprehensively reassessed at discharge. 62.0% were provided with the ICU follow-up appointment. So this they are given in detail based on the percentage. The next dimension, fourth dimension, is on effectiveness. It is divided into clinicians and the patient's perspective. We look at effectiveness. So clinicians, question number 10 is, to what extent have clinical outcomes improved compared to the previous point? So this has to be reported in a 5-point Likert scale. They have reported this. They have looked at the functional outcomes via Rockwood Clinical Frailty Scale. So they have said that 62% worsen at discharge. So based on, so this is how they are provided in the document. 32.7% of patients left in the same function. 62 of them had worsened. Out of the 62, 15.6 improved later. But 84% of people, the functional outcomes worsened. But if they have given a link in the document where you can go in the supplementary and look at the graph. Same thing is given in graph. How did they worsen, what was the problem? So they have looked at the functional outcomes and reported it. They have given an overall quality of rehabilitative care. That's also been reported. Question 1 was, to what extent have adverse reaction or complication reduced or compared with previous? So this can be given in a 5-point Likert scale. So in this particular guidelines audit, they have not looked at any data for complications or adverse effects. Question 12, to what extent has medical expenditure been reduced? So the economic analysis point of view, so this has to be given in a 5-point Likert scale. So in this particular audit, the economic part has not been done. Now looking at effectiveness for the patient, the evaluation of patient-reported outcome. How effective your treatment for this condition has been in the hospital in a Likert scale. So here they have given in another format. They have looked at all the outcomes tools utilized. Out of which this local patient-reported outcome measure is a patient-reported outcome. So they have said how many patients, they have given the number of patients based on this outcome tool. And they have also given overall outcome measures. They have given that in the graph form. They have also given overall satisfaction patient's file based on the rehabilitation center. They have also given in the patient's word. For example, I felt that once I was discharged, I was left on my own to get better with no other offer of assistance. Then this was on a thing that I think when you are in ICU, it is such a shock to you and your family. You need regular reassurance even if there are no answer. My GP was unsure what to do with me and wanted me to contact the hospital for advice. The hospital felt the GP should deal with me, and I ended up feeling a nuisance. So I'm trying to cope up with that. So this was few of the verbatim what they reported. This was another one which said my and my family were kept up to date with what was going on in the hospital. And the part of the rehabilitation they have to maintain a diary. So I found my diary was very helpful, and going to ICU steps, which is a program post rehabilitation, has helped me a lot. I still go to the meeting. They are great to talk to others about the same hospital. So this was some of the qualitative part of the Worthy Cities audit. Next question is, how have side effects or adverse reaction been during your treatment for this condition at the hospital in the 5-point scale? So here they have not looked at or mentioned any side effect or adverse, but in the information given they have support groups. So probably there is some psychological effect, but it is not specified clearly what is the effect, and they have not really looked at that point. How do you feel about the total expenses incurred during your treatment for this condition in a 5-point Likert scale? So here there is no economic analysis reported. In an infrastructure and a healthcare like that, direct medical costs may not be fully applicable. Indirect and non-medical costs, those could have been looked at, that is not reported in this audit. Effectiveness based on the quality of life. So based on ages, the quality of life has to be reported in WHO Quality of Life Brief Questionnaire. In this study, they have looked at functional outcome, discharge, frailty, address, but they have not used a formal questionnaire. So what is the WHO Quality of Life Questionnaire? So it talks about what you think about your life in the past 2 weeks. So starts with the first 2 questions are how do you rate your quality of life, how satisfied with your health. Next question is about how much. So there are questions of how much you are satisfied, how much do you need, so you can rate it. Next set of question is how completely. So it tells about do you have enough energy for everyday life? Are you able to accept your body appearance? The next set of questions are how good or satisfied you are. So how satisfied you are with your sleep? How satisfied with multiple aspects? Next is how often. This is the last one. So 26 questionnaire. 26 questions have to be answered. And they look at 4 domains: physical health, psychological, social relationship, and environment. So based on these 4 domains, the higher the score, better the quality of life. And you can use this score, get a mean in each domain and compare it with the full scale. It is a 100 WHO quality of life scale. So this is one way you can capture the quality of life. The 5th dimension is on maintenance. Did your institute make specific action to maintain the implementation? If so, what were they? You can give multiple choice. So here they have partially reported it. So they have talked about organizations which had a ICU rehabilitation lead. Rehabilitation lead is the people who make sure the rehabilitation program is done well. So they have said only 42.2% of organization had rehabilitation lead. And they have, among all this, some had rehabilitation lead. But follow-up and audits, most of them did not have. So they have given how many people who had assigned a key worker to make sure some of the rehabilitation process is done. Looks like the numbers are quite less for this. How long have you adhered to this clinical practice guidelines in months? This probably may not be very applicable in this scenario. How have you ever discontinued or stopped using this guideline? If so, when? Specify the year and month, and you can give multiple choice why. So this is not mentioned. So they have not mentioned how many people have followed or not followed, or if they discontinued why. Barriers and facilitators. Did you encounter any barriers? So they have actually mentioned it in detail. They have talked about staffing, lack of coordinators, inconsistent assessment, handover failure, and this is how they have reported. Rehabilitation care was not coordinated. They've talked about the absence of a good disciplinary team. They talked about coordinators were not available. They have talked about how MDT input was not there, goals were not shared, and the information patient got would have been less. So they have talked about the barriers to the implementation of the guidelines. Overall evaluation. So the question is, how would you overall evaluate? You can scale it from 1 to 10. So here they have not scaled from 1 to 10, but they have said low to moderate uptake, around 42%. Maybe in a 1 to around 40% is what they have said. Any suggestions for improvement? That's the last question. So here they have given 6 detailed national recommendations. And this is how it looks like. This is the first recommendation. They've given the recommendation. They have given who has to take the action, the additional stakeholders, the rationale, associated guidance, and then suggestion for implementation. That is, they have also divided it into two: trust level, patient level, and the coordinator's level. So this is the first. They have done multiple. They have given 6 recommendations in the same format. Very extensively and very well actually given. Just to summarize how it stands compared to the AGIS tool. So these are the 5 domains. So some of them are well reported, some of them are not reported, might be implied, so given marks for that. Some of them, like the maintenance and economic effect, the adverse effect is not mentioned in this current guideline which has come out. The nice guideline which they have audited. Now coming to a clinical question, have they assessed comprehensively? It's a very comprehensive and a very well written audit. Some of the aspects they have not really checked but may not be relevant in their setting. Is there another way to assess it? So if probably in our setting, if we are looking at some guideline which is already there, then these things which are not covered, like the economic effect, adverse effect, might be very relevant in our setting. So if in our setting, if we are planning to do a guideline assessment, either for quality or for research purpose, this new tool might be more comprehensive and more useful and relevant in our setting. How is it applicable to us? So same one in the performance setting. So it gives a framework for collection. It helps in converting qualitative feedback so that we can use it for research purposes and helps in auditing any clinical practice guidelines.